Good evening and welcome to UPMC Sports Surgery Clinic's evening for hikers and walkers. I'm Fiona Roach. I'm the General Manager here in the Sports Surgery Clinic. For any of you that don't know us, we are a musculoskeletal orthopedic hospital, specialist hospital. We're 10 minutes from Dublin Airport and just off the M50 and the M1. We are part of the UPMC group, and the UPMC group have hospitals in Waterford, the Whitfield in Waterford, Orthopaedic in Kilkenny, Clane in Kildare, and we have sports medicine centres across the country. So even if there's a tab there, you can see UPMC. If you don't live near us and you want to see someone, you can go into one of those tabs and you can make an appointment that way. Now, we do everything from here, from your fingers to your toes. So we do hip replacements, knee replacements, shoulder replacements, spinal surgery as well. All surgery really that affect your joints. We've 3 MRI scanners and over 30 orthopedic consultants as well, and a state-of-the-art rehabilitation and sports medicine centre. So you can see some tabs there. If any of you want to ask a question, we'll endeavour to get through all your questions tonight. So you can press that future events as well. We have another event on the 16th of October, or just on joint replacements as well. So we have 2 speakers tonight. We have Professor Brian Devitt first, and Brian's going to join us live for a Q&A after his presentation. And then we have Dr. Frank O'Leary, who will also join us live after his presentation for a live Q&A. So please type in your questions. And we will be sending out an evaluation form after this as well, so which is always great to hear what you think about the evening and any things that you think might be of help in the future. So I'm going to start tonight first with Professor Brian Devitt's talk, and which is Don't Let Arthritis Keep You Down, a hiker's guide to hip and knee arthritis.
Okay. One, two, three. Good evening. It's a great pleasure to speak with you again. I'm going to speak on the topic of arthritis of the hip and knee, and the title of my presentation is Don't Let Arthritis Keep You Down, a hiker's guide to hip and knee arthritis. So my name is Brian Devitt. So I'm going to start with a picture of a patient of mine. This is a lady I did a knee replacement on, and we're hiking here in Vietnam. So there's a couple of features. First of all, she's smiling, so she's pretty happy. She's also using a walking pole, and she's got the appropriate walking equipment, including walking boots and her backpack, and she's willing to take the assistance of our guide, which is walking up quite a steep terrain. So we see a lot of patients of ours who are interested in hill walking and hiking, and it's a fantastic pursuit. It's one I enjoy myself also. But unfortunately, they are afflicted by arthritis, which affects the knee and also the hip. And our goal is to get them back on the mountain and allow them to continue their pursuits, hopefully without surgery, but occasionally we need to intervene. So while we were in Vietnam, we learned about Confucius, and he's a fantastic quote, which I think really sums up this talk and the treatment of arthritis in general. It doesn't matter how slow you go as long as you do not stop. So that's the key factor to keep our joints moving. So we all come in different shapes and sizes. Some of us have straight legs, some of us have bow legs, and some of us have valgus or knock knees. And it also is the same with the hips in terms of the shape of our hip joints. And some of those people are more predisposed to getting arthritis, particularly people with knock knees tend to get more arthritis in the front of the knee, and they can particularly have issues walking down hills. But long before we go into the surgical field, we speak to patients in our clinic and we find out what exactly is their issue. Our main goal with any type of arthritis is to try to keep people going as long as they can. But when people start getting a lot of pain within their knees, particularly affecting them at night and affecting their sleep, that really has an impact on their quality of life. So therefore, those type of patients are more likely to present for surgical opinion if they've exhausted all non-operative measures. For the most part, GPs and physiotherapists are well able to manage mild arthritis symptoms, and I'll talk to you about the effective treatment in due course. But I wanted to start with just a few X-ray examples of those type of patients we see. So this is an X-ray of someone with bow knees, bow legs, and severe arthritis of the inside part of the knee. You'll see this on both sides. So just remember this X-ray. I'll show you a bit later how we manage this case. We also get other patients who have maybe knock knees. But if you look at the joint space here on the outside between the femur and the tibia, there's plenty of space on the outside of the joint and also plenty of space on the inside. And this is symmetrical. So this person doesn't have a problem with the inside or outside of the knee. But if you look at the knee from the side, you see that they have lots of problems in the front of the knee where the space between the kneecap and the front of the knee is quite diminished. So this person has pain on the front of the knee, or anterior knee pain, as we call it. And we do this other view where you see quite clearly that there's very little space between the kneecap and the front of the femur. So this person had awful issues going down hills or going downstairs. We then look at some people, and they have asymmetrical arthritis. So in this individual, he has a loss of joint space on the inside of his left knee, but his right knee is fine, and the outside of the left knee is also fine. So how do you manage these cases? And we'll see an example later on. And we look at the front of his knee, and there's plenty of space between the kneecap and the femur. We also look at people with hip arthritis, and I deal with many of these patients, and we see quite clearly on the right hip that the hip is superiorly migrated, so it's moved up compared to the left hip, which is a ball and socket joint. But you see the ball here has lost its position, and you see there's lots of little cysts, these grey areas within the femoral head, which is as a result of severe arthritis. So this individual is a keen mountain walker, but couldn't walk because he had a marked limp on the right side, and you can see why. And then we have individuals who have arthritis of both hips, and they really notice that their stiffness is a big issue. So really struggling to put his walking boots on, or struggling to really just get up a hill because he can't lift his or flex his knee because his hip is so stiff to get up those steep inclines. So I'm going to go back to school now for a bit of physics, and you'll see why Isaac Newton was so right. And he wasn't an orthopedic surgeon, but he knew a lot about gravity and the effect of gravity. And we also know that when people have a lot of weight on or are hiking, that the load going through their knees, particularly going downhill, tends to be a lot more. So if we talk about the weight that goes through our knees or hips when we walk, so we're just walking, twice body weight goes through our knees on average. When we're walking downhill, that increases to 4 times. So we often feel a little bit exhausted going uphill because of the physical demands, but going downhill is what really hurts our knees. But if you're running downhill or running on any surface, it's 8 times your body weight. So one of the first treatments of arthritis in individuals is to reduce your body weight. And that reduces the load going through the knees and the hips. So it's a key factor to remember. Let's just take a calculation of an example. So 100 kilogram male, so you can imagine a little bit overweight. It's 400 kilograms walking downhill that individual is putting through each knee. When we talk about a 10 kilogram weight loss, so it's 10% body weight, that's 40 kilograms less per knee per step going downhill. So it's significant the impact that this has on the treatment of people with arthritis. Well, let's talk about specifically how do we avoid injuries while hiking. Well, I think the key factor is knowing your limits. So we're not going to start off climbing Everest in terms of our pursuit. We're going to do probably more of a flat walk initially and then increasing to an incline. We also recognize we need to improve strength around the ankle and our general core and strength and our stability within our abdominal muscles. So I often recommend Pilates as a fantastic exercise, particularly reformer Pilates, for a holistic body approach to maintaining strength. One of the simple factors is using walking poles, and we're able to dissipate the load going through our knees by helping our knees out with our arms, and it adds to good balance. So walking poles are a fantastic addition when we hike to help our knees out. It's also important to wear the appropriate footwear, so we're not going to go walking with these type of sandals, as you'll slip, or something with a bit of ankle support is appropriate. And it's also appropriate to have the rest of your clothing correct, that if you're walking on icy environments, you need some type of crampon or something on your feet so you can actually get some grip. And just be cautious going out if it's very slippy, because you will injure yourself and sustain a fracture and also exacerbate arthritis on occasion. It's also really important to hydrate adequately, because then you have better physical function. You'll be more equipped for the pursuits that you're going to engage in. So let's just look at the treatment that works with arthritis. There's a variety of treatments which people have been promoting over the years. And this is a very famous quote from Macbeth. "Eye of newt, toe of frog, wool of bat, tongue of dog, adder's fork and blind worm's sting, lizard's leg and howlet's wing, for a charm of powerful trouble, like a hell broth boil and bubble." And I bring this up because it's amazing how many people come up to me and have all these outlandish types of treatments. And none of these work for arthritis, by the way, but it's important just to stick to the tried and trusted in my mind. If we look at just a Google search of arthritis, you'll find a whole array of different treatments, and oftentimes it's the sponsored ones are the more wacky ones, with laser therapy, people suggesting stem cells with no backup in terms of evidence. So I really think it's important that we stick to the tried and trusted. So let's look at the non-operative approach, or conservative management, as some people call it. So keeping up your activity is really important. So by staying still, as Confucius told us, you're really going to struggle. So you don't want to stop. Keep active. But you want to do exercise that is not going to affect you or going to, give you those sleepless nights because of pain. As I mentioned, and I showed you the equations, that weight loss is really important. Probably one of the best methods of reducing the pain with arthritis. Acupuncture, hasn't been found to be hugely effective, but it doesn't do any major harm. But I wouldn't spend a lot of money on it if it's not going to do good. Massage can help out. That sometimes if your muscles are a bit crampy, particularly around an arthritic knee, that can be helpful. Using braces provides a little bit of support, but hasn't been shown to reduce the progression of arthritis. Insoles, likewise, they make you kind of feel that you're a little more secure in your footwear, but haven't been found to reduce arthritis. Glucosamine has not been found to be effective, but it's a cheap, easy medication to take. And in my mind, if people want to take it, I don't discourage them. If it has a placebo effect, at least, that's good enough for me. We look at the pharmacological treatment and we see anti-inflammatories, and they're very effective because anti-inflammatories reduce the fluid within the knee. When you have fluid within your knee, you're more likely to have inhibition of the muscles, particularly the quadriceps, the muscles at the front of the knee, and they're very active when we're walking downhill. So if you can activate those muscles, because when you fluid, they don't activate. If you get rid of the fluid and can activate those muscles, you tend to be much less symptomatic. Steroid injections can occasionally be helpful, but they don't alter the natural history of the condition. They just give you a bit of pain relief. And similarly with hyaluronic acid, which is a chondroprotective jelly, that can be helpful, but only really in the early stages of arthritis. And it's typically to give you enough pain relief that you can get on with your strengthening exercises. Platelet-rich plasma, once again, the jury's out in terms of its effectiveness, but it has been shown to be effective in certain studies. In terms of surgical treatment, in the past, people used to get an arthroscopic washout when they had arthritis, and we no longer do that because it hasn't been found to be effective. Occasionally, if there's a displaced meniscal tear with good joint space, we can do an arthroscopy to remove a displaced tear, but it tends to be not the gold standard treatment nowadays. We can change the shape of the leg if there's too much load going through one side of the joint. And this is typically reserved for younger patients. And this is a salvage procedure to offset or postpone a joint replacement later on, but it can be very successful in certain cases. And joint replacement therapy is extremely successful when needed. And we try to push this down the road as long as we can. But when we do it, patients tend to do very well following joint replacement. So let's just revise or go back to some of the images we saw. So this is the first case of bilateral, so both knees affected with arthritis. So in this individual, they have arthritis, particularly of the inside, but also severe arthritis at the front of the knee and also arthritis towards the outside of the knee. So in this case, this individual got bilateral knee replacement. So we actually did them at both at the same time because she had severe arthritis, which affected both legs. So nowadays, we're more likely to do both sides if both sides are affected. Obviously, if only one side is affected, we just do that side. But it stands to reason if you reduce your rehabilitation, the risks aren't significantly increased by doing both at the same time. But if one leg can't achieve full extension or full straightening, and you're doing a joint replacement on the other leg, it really is hard to rehabilitate. So that's why we do both together. If they're both affected, we tend to treat both at the same time. So this is the example of the patient who had the valgus knee with the arthritis under the kneecap. So in this case, as we saw previously, the joint space on the inside and outside of the knee was well preserved. So we just did an isolated joint replacement of the kneecap joint. And this was very effective for her. Her issue was walking downstairs and walking downhill. And because she'd really no arthritis on the other side of the joint, we did an isolated patellofemoral joint resurfacing. So this is a very effective treatment for her, and she did very well and got back on the hills. This is the other example of the isolated unicompartmental knee arthritis, so just the one side of the knee here on the left side, the inside of the left knee. And this gentleman, we did a partial knee replacement of just the inside of the knee. And once again, he got back to all his pursuits without any major issue. And in this case, his knee felt really just back to normal because we hadn't taken away any of the ligaments and we just resurfaced the side of the joint. So you see it quite clearly here, and we're just resurfacing that side of the joint and putting a metal resurfacing and then a plastic in between the two sides of the joint. So one of the tibia with a tray and plastic, which you can't see in the x-ray, lies in between the two joints. So in terms of your knee replacement, what I always say is for knees in particular, earn your knee replacement. The key factors are weight loss, modify your activity if possible. If you need to use walking aids, really effective, maintain your strength and physical activity, and use anti-inflammatory medication. From my perspective, there's a limited role for arthroscopy, and only seek to have a knee replacement when you're ready. And your surgeon will speak to you about this and try to exhaust all non-operative measures before you go down the route of surgery. And these are typically the indications are night pain and significant quality of life issues. If it's really affecting your ability to do things you want to do, it's key and really important. The next question I asked is, how active can I be with a knee replacement? And nowadays, we let people do whatever they want to do, really, in terms of getting back to their own activity. You recognize that people are probably going to run a marathon at that point. When they get arthritis, they tend to be slightly on in years, so it's not in their interest or their to run marathon. But a lot of people come back on the mountain, hiking, skiing, and really do whatever you want to do. And we're not very particular in terms of limiting you, but most people will be certainly limited in their own exercise tolerance. But we definitely encourage to get back to most activities. I want to share with you a quote I got from a patient of mine who's a farmer, and he misread the post-operative reviews. Instead of coming back at 6 weeks, he came back at 6 months. And I asked him, did he have any pain? And he said, occasionally I get pain. I said, when do you get pain? And he said, after shearing 50 sheep. So he was a very active man with his knee replacement. But he told me something very insightful, and I share with a lot of my patients. He said, I quickly realized that it was a case of me getting used to my knee. It was a case of my knee getting used to me and not me getting used to my knee. And it was really interesting just to turn it that he wanted to get on with his pursuits and his knee just had to come along with him. He wasn't going to sit down and mollycoddle his knee. So it's a very nice quote, I think, from his perspective. And I think it sums up what we expect for patients after knee replacement. So finally, I just want to show you the other examples we started at the beginning of the talk. And this is the example of severe hip arthritis. And I do the hip through what we call an anterior approach. So we divide between the muscles at the front of the hip. And this allows people to get back to their activities very quickly. And this is an example of how we template the hip. So we use the x-rays and we measure the appropriate size. And the advantage of doing it this approach is I can x-ray during the surgery. So I can try to mimic what I've templated and also ensure that we get the prosthesis in a good position. And this is the final product. So this is a nice hip replacement. So you see the hip is nicely balanced now. And this individual is back to all his normal activities within 3 months of surgery. The advantage from my perspective with the anterior approach is that we don't have as many precautions. So some people are restricted in how they lie in bed. We're happy for people to get up and walk the same day of surgery and get back to their normal activities as quickly as they can. And finally, the other example of an individual who has arthritis, particularly affecting the right hip, but also arthritis of the left hip where there's extra bone forming here. So this is the man who really struggled to walk up hills because his hips were so stiff and couldn't put on his walking boots. Well, just like when you've arthritis of both knees, we did a bilateral hip replacement in this individual. So the both combined procedures take less than 2 hours, and he was up and walking the same day of surgery. So he was back to all his normal activities as well. So we can certainly nowadays can manage most arthritic problems with ease, but the key factor is when we choose surgery, and the key decision maker in that is the patient. So my objective is to get you back on the hills, get you enjoying the outdoors for as long as possible. Thank you. I'm happy to take any questions.
It's a really interesting talk. So we have a few questions coming in already there. We'll start with Paddy Callahan. RE cartilage in knee joints. Do most people have an infinite amount of steps or mileage possible without needing knee or hip surgery? Or should very fit and active people in their 70s be reducing their amount of physical exercise? Do they need to minimize the risk of needing surgery?
Hi, Fiona. Yeah, that's a very interesting question. I think in many respects, there's a genetic predisposition to developing arthritis. So we can't really fight genetics, but we can fight our environment and what we put into our bodies. And I think, really keeping fit as we age is so important. It's important for our physical well-being, but also our mental well-being. And I think moving as much as we can, within reason, I think is really important as we age. But keeping your body weight down it puts less load through your joints. So definitely keeping a really physical and active activity level is hugely important.
Good, thank you. Fiona, is there anything you can do to prevent further deterioration of knees that is non-invasive? Do supplements help? Any exercises can help strengthen the knee, prevent pain? Going downhill is very painful. I'm now 60 and really want to remain fit and active. What should I do?
Yeah, so a lot of the stuff which I kind of mentioned in my talk kind of recovers this point. And really, we want to look at the tried and trusted methods. And one of the things that we're very big on in UPMC SSC is using evidence-based practice. So, supplements have not been shown to really reduce the rates of arthritis, but they don't do any major harm. So if you feel it gets some effect and individuals can benefit differently, I would have no problem recommending them. The key factors is keeping the muscles strong around the body, and doing exercises to strengthen the quadriceps is particularly good for going downstairs. You can have minimally invasive procedures like injections can be helpful in the short term. But as I mentioned, once the pain gets so severe that it affects your quality of life and particularly your sleep, you're looking at more invasive methods like joint replacements, which are very, very successful.
Thank you. After joint replacement, are there restrictions one should observe when hiking or hill walking?
Well, I think you just need to be sensible regarding what to do afterwards. And we recommend in the early phase that really the key focus is regaining range of motion and normalizing one's gait. I think that's really important. So we walk before we run. And I think, doing the likes of hiking is a little bit more robust, and it requires more energy, and it puts the knees through a greater degree of load. So we have to be prepared for that. I think building up the strength in our lower legs is really important before we embark on a hike. And I think then it's also just listening to your body. I think in the early post-operative period, there's still a lot of swelling. I have a little phrase that with respect to the wound, that once the wound goes white, there's no pain at night. That once you see your wound whitening, you mean the inflammation has gone, and you stop having discomfort in the evenings. And that's really a good phase where you get back into the more rigorous activities like hiking.
Okay, thank you. What's the life expectancy of a hip replacement joint?
It's hard to say. I think the modern hip replacements really are fantastically manufactured, and they can last for a really long time. I was at a conference recently, and one of the presenters was asked that same question, and they had a good answer, which says that there's a failure rate of 1% per year that the hip replacement is in. So if you think about 20 years, you have a hip replacement, there's an 80% chance that hip is going to be functioning very well. And that's failure for all causes. So I think that kind of rule of thumb probably applies.
Okay, thank you. lady. She's 9 weeks post knee replacement, still has pain at night, but it's early there. She's good movement, physio's happy with her. How soon would you recommend hill walking? She's doing a lot of strengthening exercises in the gym. She's only 9 weeks still.
Yeah, so as I said, that kind of fits into my phrase, no
Yeah.
pain at night if the wound, yeah. So I think that you'd expect the pain to dissipate by probably 12 weeks, so 3 months post-operatively the pain. So to have a little bit of discomfort is no harm. And I probably emphasize that she's doing some good work as it sounds from her range of motion. So really, she can start integrating maybe some gentle inclines in her walks, and definitely take some walking poles and really start getting back into it. But start with small little hikes, not too long. Don't get stranded up a mountain and in pain. And if there is a little bit of discomfort after a hike, there's no harm at that stage taking some over-the-counter anti-inflammatories if it is a little bit painful. But we're very much of the opinion you need to use your knee, and as I mentioned, that quote. Don't let your knee define your life. You just go on with your life and your knee will follow.
Okay, thanks. Someone here, they've a labral tear in the left hip, very active in various sports, including hiking, but what can they do to prevent it returning regularly?
Yeah, so I think it's kind of labral tears in the hip are kind of an awful lot of times they're a precursor to developing arthritis. I think, if they're very painful and, there's a lot of swelling in the hip, they're taking anti-inflammatories is very important. An injection can be helpful if there's fluid in the hip, and a lot of these labral tears will settle down with time. So it's kind of avoiding any kind of deep flexion can be an issue. So if the individual is hiking in very steep inclines, that might exacerbate the pain. So building up the strengths and just treating the inflammation is the key factor in managing labral tears.
Okay. Someone's just asking about, do knee issues interfere with the lower back?
They can. It relates to the posture one has when they walk. I think it's really important. If you can't extend your knees, you tend to walk with the more flexed posture of your knees. And if you try to walk with your knees flexed, you'll find your hips flex over, and then it puts a bit more strain to your lower back. So we often find people, particularly with hips, actually, less so with knees, but do present with lower back pain. And oftentimes when you resolve the contracture or stiffness within the hip by a hip replacement, the lower back improves. It doesn't completely settle in all cases because you can have arthritis there too, but it typically improves. And likewise with the knees, if you get the knees straight.
Yeah, thank you. Some doctors don't recommend diphenol or anti-inflammatory medicines. Do you have any views on this, and how regularly should they take analgesia if they're hiking?
Yeah, well, I have no problem with people taking diphenol, provided there's no contraindications in terms of other medications they're taking. But occasional diphenol is not that harmful, and if it's taken as per the recommended methods after food, and if there's any gastritis, you can take some proton pump inhibitors to help the stomach. But really, occasional diphenol is helpful if you have inflammation, and in fact, it's very useful to reduce the inflammation in a joint and allow the muscles work. So I'd say it can really treat a lot of problems very nicely. If you're taking it on a daily basis, that's something that you need to look at and discuss that with your GP, because it probably heralds that your joint is worse than you maybe think it is.
Fine. Thanks very much for joining us tonight. And
Thank
now
you.
we're going to have Frank O'Leary's presentation. And Frank is a guide for hill walkers on how to prepare and avoid injury. Thank you.
Good evening, everybody, and thank you for joining this talk on hiking for health, a guide for hill walkers and hikers on how to prepare and avoid injury. My name is Frank O'Leary. I'm a consultant in sports and exercise medicine here at the UPMC Sports Surgery Clinic in Dublin. So what I'm going to be talking about this evening is certain health benefits of hill walking and hiking, how you might prepare for an event, some of the common musculoskeletal injuries that might be involved as a result of excessive hiking or excessive hill walking, some of the injury prevention strategies before a big hike or a walk that you might be predicting, how to manage certain extremes of temperatures, and then a few slides on skin and wound management that are common issues around hiking and hill walking. What I won't be covering is altitude sickness and complications from high altitude, and I won't be covering high adjuncts like footwear and certain hiking sticks. So if we just go back to the physical activity guidelines and what the Chief Medical Officer advises what adults should be doing from a exercise, both aerobic and anaerobic perspective. So adults aged 18 to 64 years should be doing about 150 minutes of moderate intensity aerobic physical activity or 75 minutes of vigorous intensity aerobic physical activity per week. Now, you might say, well, what's moderate and what's vigorous? And often I talk to patients about a thing called the talk test. So if you can talk while you're doing the exercise, then probably it's moderate. If you can sing while doing the exercise, it's probably less than moderate and mild. And if you have to take a breath between each word as you're doing the exercise, then it's probably vigorous. And a lot of people do fulfill this, but what they forget about is the strength-based stuff. So you should be doing about twice a week strength-based work. This can be in the gym, this can be yoga, this can be carrying heavy bags, but it should be part of your week. And then if you're over 65 years, you should also be doing some balance work as well as strength-based work. And again, this can be different aspects of activities like dancing or bowls or Tai Chi, so on and so forth. Unfortunately, in Ireland, only about 31% of adults fulfill all of these criteria for physical activity, and 12% of adults don't do any physical activity at all per week. In terms of hiking and hill walking, the cardiovascular benefits are evidently there. It helps reduce blood pressure. It also helps improve mood and anxiety levels, and does help to reduce the risk of osteoporosis and help manage osteoporosis through its load-bearing capacity. What makes hill walking and hiking unique is the change in terrain, the uneven terrain, and then the unstable terrain. So you may not be sure-footed when you're going up certain mountains. The environmental exposures, be it hot or cold, also make it unique to hiking and hill walking, as well as access to certain services like the emergency services. In terms of medical preparation, if you're thinking about a long hike, you might want to discuss, if you're going in a group, about certain medical conditions that you might have. For example, type 1 diabetes, to alert people that maybe you are a type 1 diabetic and that it will be unusual if you display certain symptoms that might be a sign of that your blood sugars are either too low or too high. Similarly with heart issues. You might want to alert people as where your emergency medications might be it insulin, be it an anapen if you have severe anaphylaxis, or be it glucose for type 1 diabetes. Medical clearance is one of those ones that always comes up sometimes in amongst doctors, of whether patients should come and be medically cleared for a hike or a hill walk. Often you don't need it. However, if there's been a change in your condition or a change in your medications relatively recent, you might want to consider it. And then ultimately, the big medical prep is the training, both aerobic and anaerobic. Just some of the practical aspects of hiking and hill walking. It's like any event, you need to prepare in advance. You should think about your route and know about it as best possible. Speak to people about the route. What are the dangerous paths? What are the risky areas? Know the emergency contact details. Bring a phone with you. Check if there's coverage in the area. Inform people of your travel and estimated time of return. Preparing for certain weather extremes, be it hot, cold, foggy, etc. Think about what you would do if someone got ill or got injured at certain points of the route. Bring some first aid kit with you, like bandages, plasters, and antiseptic solution, and bring certain things with you that in case you do get stuck, like food, water, torches, blankets, etc. So I'm just going to talk a bit about temperature extremes, hot and cold. So heat illness is, exertional heat illness is when the core body temperature rises as a result of exercise. This is as a result of increased muscle activity and metabolism. So the balance is lost between heat loss and what's heat generated. The heat is lost through sweating. In hot and humid conditions, the sweating becomes less effective, and therefore you have reduced sweat evaporation and the body can overheat. Now, at the end scale of this, a medical emergency is heat stroke, which is life-threatening. And this is when your core body temperature is above 41 degrees centigrade. Some early signs of heat illness might include fatigue, weakness, dizziness, diarrhea, vomiting, confusion, or change in behavior, be it aggression, irritability, or hysteria. Now, these are very non-specific signs. And if you think back in the last slide about type 1 diabetes. If your blood sugar was very low, you might have some similar symptoms. So it is very non-specific, but if someone is displaying some of these and it's a very hot day, you might want to think about heat illness. It's important to state what heat illness is not, and it's not dehydration, it's not due to lack of fitness or due to a low glucose. The main management for heat illness is to cool the body, and this in whatever means possible, be it cold water immersion, ice, fans. If you have ice, you put it in areas like the axilla, the groin, the head, the neck. These are areas where there's excellent vasculature. In terms of preventing heat illness, getting acclimatized to the hot and humid conditions is essential, and people should avoid exercising if they're unwell, especially things like viral infections, as this can increase the risk of heat illness. If we think about the cold, accidental hypothermia refers to the involuntary drop in core body temperature below 35 degrees centigrade. And this can be caused by exposure to cold air or cold water, and can be as a result of your own body not being able to thermoregulate. Sometimes this can be a result of certain traumas like burns or alcohol or drug use. Some early signs of being excessively cold would include shivering, cold hands or feet, palpitations, rapid breathing, and mild incoordination. The main management, again, is passive rewarming. So just warming up the body, removing any wet clothes, cover the body with blankets, and trying to remove them from that environment. If you can't remove them from that environment, then consider removing the wet clothing, or if you nothing to replace it with, keep the wet clothing on, cover them with blankets, and then use a plastic bag over that to kind of keep the heat in. Active rewarming involves using hot packs, and you need to be careful if someone is severely hypothermic, as too active rewarming of the body can result in a worse outcome. In terms of musculoskeletal preparation, the main areas to focus on in regards to hill walking and hiking will be the calf muscles, ankle stabilization, quadriceps strengthening, and hip stabilizers. If we focus on the hip, you can see some of the exercises here that you can do, and you don't need a gym for this. The first one on the left is the goblet squat. And literally you're going from sitting to standing. So sitting in the upright 90-degree position and then standing. You can add a weight and carry a weight for this. It doesn't have to be a dumbbell. You could use a heavy book and simply go from sitting to standing. This activates the buttock and the abdominal muscles. Hip abduction means bringing your leg out to the side, and this activates the lateral hip muscles, which are important for leg stabilization. Hip extension, again, can be used to activate the big gluteal muscles and the hamstrings at the back. And this can be done with a stretchy band, which is available in a lot of shops and retail outlets. And then the bridge is useful for activating hamstrings and glutes also. In terms of quadriceps, again, you can do this at home. The picture on the left can be a little bit challenging because you're doing it single leg. And if you're at risk of falls, I'd advise avoid doing the picture on the left, that exercise. Maybe you could do the one on the far right, which again is a sit to stand or a sliding squat against the wall. And then once you get comfortable with that, move to the single leg RDL exercise, which involves activating the squat, activating the quadriceps muscle, I should say. The unique thing about hill walking and climbing is the uneven terrain. So you may have underlying issues like a dodgy ankle or unstable ankle or a bit of arthritis in the big toe, and it might be fine on the flat. But once you get into the uneven, unstable terrain, it can flare up. So things like osteoarthritis of the big toe, ankle instability, hammer toes, Achilles tendon issues, plantar fascia issues, or even knee osteoarthritis. These may all be stable and relatively mild on the flat terrain, but when you go into the uneven and unstable terrain, it can really flare up. So you need extra strength in the particular areas I mentioned in the previous slide if you want to go ahead and go on hill walk and a hike. Some of the common areas that are injured would include the ankles, the knees, the calves, the feet. Sometimes you can get head injuries and muscle cramping and fatigue. If we think about what happens when you go up and down hill, the forces change going through the joints. So if we think about going downhill, we place a huge amount of stress on our knees and our quadriceps. This is because on the way down, the knees and the quadriceps need to take a huge amount more force to try and slow us down and break the body. So there's about 3 to 4 times the force going through your knee downhill versus then through your knee going on the flat. If we think about going uphill, there's less work on the knee, but there's more work on the hip and the ankle, and it requires more energy to get ourselves uphill. So the main movers here are your calf muscles and your hip muscles, which would include the glutes and the hamstrings. I'm going to talk a bit about foot injuries, mainly stress fractures and plantar fasciitis. A stress fracture is a fracture. It's a partial or complete fracture that results from repeated application of a stress that is lower than that stress required in order to fracture the bone in a single loading. So what that means is, rather than get one single blow and fracture your foot, for example, it's the repetitiveness and repetitive strain that ultimately leads to a fracture in the foot. The risk factors for stress fracture would include loading up too much, so doing too much too quick. If you're weak in the muscles around that bone, if you have thin bones or osteopenia or osteoporosis, if you're low in vitamin D, or certain sports and exercise like endurance sports, which would include long distance walking and hill climbing. The main management for a stress fracture is offloading. The main symptoms are pain. Sometimes you can have swelling, sometimes not. But the pain then, once you offload it, take your weight off, the pain tends to settle. But if you go back to that previous activity, the pain flares up again. So typically, if there's a stress fracture of one of the foot bones, we put you in a boot to offload the stress going through that bone. We would address the risk factors, and then we'd ask you to build on your strength. Plantar fasciitis is a very common condition that we see a lot here in the sports surgery clinic. So ultimately, it presents with heel pain or pain around the arch of the foot. Pain is worse when you get up out of bed and you start to walk. So if you rest for a long period of time and you go to start walking, you'd feel the pain significantly. Generally, it eases as you keep walking, but then it can flare up again as you return to rest. It's difficult to lift your heel off the floor in plantar fasciitis. The main management is, again, stretching, calf exercises, for example, the heel raise, as you can see in the picture here. On the left is a double heel raise, which is easier than on the right is a single heel raise. You can wear something like a night splint, which keeps the ankle bent and keeps that stretch on the plantar fascia. And then we have other adjuncts here in the sports surgery clinic, like shockwave therapy, and occasionally we need to inject the area to help move it along in its management. In terms of ankle injuries, the most common injury is an inversion injury when you roll your ankle, and this affects the ligaments, the outer ligaments of the ankle. And then Achilles tendon flares or even tears can happen. If we look at the ankle, there are major stabilizers of the ankle, and there are 3 main ones on the outside, and these are the ligaments. Their main function of the ligament is to stop movement, stop the bones moving between the joints, to give some stability to the joint, and then provide feedback to let you know where your foot is planting. Occasionally, if you roll your ankle, you can fracture it as well. The most common injury is the ligament injury, but occasionally you can fracture. So if you do roll your ankle and you're finding it difficult to put your foot down, and it's getting worse and it's a lot of swelling, you might need to seek medical attention. The lateral ligaments, if they're injured, the main treatment is to get the ankle moving better, so getting the range back, getting the swelling down through compression, and then building up the strength in the ankle muscles around that joint. And some of them you can see here in dorsiflexion and plantar flexion, so moving the ankle up and down against resistance to help build that strength. If we look at the Achilles tendon, which on the MRI scan here is the black line at the back of the ankle coming down. So the Achilles tendon is the strongest tendon in the body. It attaches the calf muscles down to the heel. There's a huge force that goes through the Achilles tendon, and it's a common site of injury. You can see here on the MRI scan where the Achilles tendon comes down in a line, but then it becomes thickened. And this is the mid portion of the Achilles tendon, and it's a common area to be injured. The main treatment for it is strengthening, a loading program through calf raises and calf drops, and build on that strength as you get more proficient. There are again some other adjuncts that we can use here and that we've used in the sports surgery clinic, which will include shockwave therapy and injection. If you completely tear your Achilles, it generally feels like a sudden pop or a sudden tear. Some people describe it like someone being shot in the back of your heel. There's significant weakness in your ankle, there's pain in the back of the heel, and there's a notable gap. And you lose the contours of your Achilles tendon. You can see in the picture below where on the right, you've got a nice heel and Achilles tendon coming up, where on the left is just swelling and there's no definition. You'll have difficulty bending your foot and pushing your foot away. In general, for Achilles tendon pain, the pain is worse in the morning and worse. It can warm up with movement and gets worse after movement. There can be swelling in different areas depending on where the tendon is injured. The two most common areas where the tendon is injured is the mid portion and the middle of the tendon, and at the insertion as the tendon inserts into the heel. The pain can be the day after or the evening after exercise. So often during exercise, you can warm up the tendon and the pain eases off, but then towards the evening, it starts flaring up again. For mid-portion Achilles tendon problems, generally this is what a loading program might look like. And with heel raises, heel drops, with the knee straight and the knee bent. And these can be done not just for treating Achilles tendon, but if you want to build up the strength before you do a long hike in your calf muscles, these would be some of the exercises that you would do. Calf injuries are very common. There's two main calf muscles, the gastrocnemius and the soleus. Gastrocnemius is the real powerhouse, is the producer of power in short, sharp bursts, where your soleus is an endurance muscle. Gastrocnemius tears, you'll generally know all about it. It'll feel like a pop. It'll feel like you're being shot in the back of the leg if there's significant tear. Soleus tears are much more subtle and often just feel like a strain, and you mightn't notice it as much. In terms of cramp with exercise, or that sense of calf cramp, often it's due to deconditioning and fatigue. So often it's due to the muscle not being able to produce the force or the level of activity that you're demanding of it. Things you may need to consider that you might need to seek medical attention for would be, is it a blood supply issue? So is there enough blood supply getting down there? Or is it referred pain from the lower back? So if you are doing conditioning and you can't progress through calf pain, you might need to seek some medical attention. I'm just going to talk now about some skin issues that are common when you hill walk and hike. And these would be blisters, wounds, bites, and sunburn. In terms of blisters, prevention is better than cure. So if there are certain areas of your foot that you think are going to be at risk of blisters, then you're better off just covering them with things like Hypofix, like you'd see in the picture here. So risk factors for blisters would be new shoes, poorly fitting shoes, heat, or any foot abnormalities like bunion or hammer toe that you might have, or running or on a regular surface. If you have new footwear, then try to protect those particular areas that you think are vulnerable with some tape, like you can see here. If you do get a blister, try not to burst it if it's relatively small in size. And often you can use plasters like hydrocolloid plasters to give it that cushion, which can come in various sizes. If there's a large heel blister, you might need extra padding at night to get you a night's sleep. And if the blister is burst, try and remove the dead skin around it, clean the area, and apply a dressing. In terms of wounds, if you're out in the wilderness and you do get a wound, try and clean your hands, maybe bring some alcohol gel. If you can, bring gloves. If not, it's not a big issue. Clean the wound with clean water, remove any debris, apply antiseptic, and just cover it with some bandages or plasters, like you can see here with the picture. Sunburn is an issue even in Ireland, and clothing is the best form of sun protection. You should wear sun protection even if it's cloudy, because about 70% of the rays still get through the cloud. And you should look at the sun cream bottle that you have and make sure there's UVA and UVB protection. Vulnerable areas would include the scalp, the nose, the ears, and the lips. And risky environments would be if you're out in water or prolonged exposure or between the hours of 11 a.m. and 3 p.m. If we look at insect bites, try to avoid areas of stagnant water where insects love. Avoid skin exposure at certain times, like dusk or at night, and try to keep yourself covered with long sleeve bottoms. Wear insect repellent if you can. So that's everything from me. Thank you very much for listening, and I'm happy now to take any questions.
Frank, thank you for a really interesting talk. There's a few questions coming in, so I'm just going to start with those. There's one from Brian. He's 67. He's had 2 successful knee replacements. He's very active. He now has arthritis in his foot, which is causing pain. He's had injections like he did before his knee replacements, but the foot injections aren't as effective as the knee ones. Is there an alternative, or is hiking days over?
Okay, thanks, Fiona, and thanks for that question. I would firstly, I'd encourage you not to give up hiking. I want you to keep as active as you can. If you're getting foot pain and there is some arthritis there, I think one of the things you can do is look for a biomechanical assessments and look at the way your foot moves and look at certain strength markers in and around your ankle and foot, and even higher up in your calves and your knees. Because often if there is excessive loading on your foot, it's because other areas are weak, likely your calves, likely you're higher up in your quadriceps, and even in your hip and your pelvis. So I wouldn't give up yet on the hiking, and I'd look at maybe getting a biomechanical assessment and see what way you move. And certainly we can do that in the Sports Surgery Clinic. We've got guys there that are very good at assessing that. The injections are good, and they give you some time and space so you can build up your strength without causing too much pain. But there might just be something to do with the way you're loading through those joints in your foot, because there are plenty of them.
Thanks, Frank. What would be the plan of action for someone who comes in with plantar fasciitis?
So it's a really common condition that we see in the Sports Surgery Clinic, and it can be quite debilitating. So it's pain at the source of your heel, and it's to do a lot with again, too much loading through your foot and your ankle. So your plantar fascia is like a tight band, and if that's too much force going through that, then that can flare up and cause pain. Typically, again, we look at someone and see what level of pain they're in. If they're in really, really bad pain, we might offload them in a short walk or boot, and to try and offload the force going through the plantar fascia. And then we can consider other adjuncts like shockwave therapy, which actually causes a little bit of inflammation at the source of that heel, to cause then your own body then to act in an anti-inflammatory way. And then other things we can do, we can inject the plantar fascia. Again, these are in kind of extreme cases. In most people, it settles down on its own, but you need some guidance in terms of building up the strength, especially in your Achilles and your calf. And it's about how you can do that. And it takes time. It takes about 3 to 4 months to kind of recover from that.
Okay, thank you. And this is they've continually spraining their ankle. Is there any way they can prevent that?
Okay, once you roll or sprain your ankle once, your risk of you doing it again in the next 12 months is significantly higher. About 2/3 of people will do it again. So it's about giving your ankle some stability. So that's the purpose of ligaments. They hold your bones together in and around your ankle. If one of those ligaments sprains, it does scar up a little bit, but it never fully recovers to the way it was. So what you need to do then is build a strength around your muscles. So depending on what side the ankle was sprained, if most common people it's the outside, then you need to build the muscles on the outside. And that can be done through exercises under the guidance of physio and building up through the strength. If it's too painful, you can come and see one of us and we can consider things like injections, but most of the time people don't need that, and that they able to build up the strength. But strength building takes time. For you to feel different and stronger and stable in your ankle, you're talking about 14 to 16 weeks of work. Even though you might feel good at kind of week 6, week 8, it's going to take that extra bit of time to build up the strength in your ankle, and that will prevent recurrence, especially in hill walking where you've got that uneven terrain and that unlevel terrain.
Okay, thank you. How long does it take to fully recover from an Achilles injury?
it depends on how bad the injury was. I'm not trying to be difficult about that. It does honestly depend. So if you've got, I'm presuming that there's no complete tear and there isn't any surgery. If there's a partial tear or inflammation of the Achilles, the main thing is to try and calm the pain down. And sometimes people need, again, if they're extreme pain, they need a boot for that. Other people are able to start doing rotational exercises and building up the movement through their ankle. But typically with kind of strength and conditioning and building the strength through your calf muscles, this can take up to 3 months to kind of typically recover, and for you to feel stronger in yourself and confident in yourself to go and do things like hill walking. Again, the uneven terrain, the unlevel terrain, the underneath you will put excessive strain on that Achilles tendon, especially going uphill.
Okay, thank you. The question here, like, I think someone says they're post-arthroscopy, knee arthroscopy for a torn meniscus. They're starting to walk without crutches now, 6 weeks. They're 73, fit and healthy, and I think they used to walk a lot. I think they're kind of probably asking when's a good time to maybe start hill walking again.
Okay. So if you're that sounds like early days still after an arthroscopy, about 6 weeks. The main thing is that has the swelling come down to the level that of before the arthroscopy, and have you got your full range of movement through your knee? And then after that, once you've got your range of movement, then it's about building your strength. Your quadricep muscles will unfortunately quite quickly waste away if you haven't been using them. But the great thing is they will come back quite quickly as well. So I think you need to, after you get your range back, to build on your strength. And once you feel confident walking, on day to day on the level terrain, and then you can start doing inclines in a safe environment before you would go out on a mountain or a hill. And then once you feel comfortable and you don't get reactive swelling to that, then you can start short hill walks and hikes. Everyone's a little bit different, but again, going back to strength and conditioning, to feel stronger in your knee, you're looking at 3 to 4 months to feel that difference. So it may be that time. Some people are a little bit sooner, but on average, it would be that kind of timeline.
I get severe pain descending, so going downhill. I think this is a common question sometimes in my right knee, how to prevent.
So when you go downhill, I think I mentioned in my talk, there's far more force going through your knee, far more, about 3 to 4 times than if you're on the flat. So ultimately you need stronger muscles to take that load. And ultimately that's working on your quadriceps. Because they take the vast majority of that, and your quadriceps, quad is 4, so you've got 4 muscles there that come into the tendon, into the top of the knee. So really, to prevent that kind of flare up and that pain, I think you need to build up on your quadriceps, not to the point that you're pain-free on the flat, but to the point that you're pain-free going downhill. And I think you may have built on your quadriceps already, but it's just about building more on that, and that will prevent further loading on your knee. And then there's other areas higher up in around the hip muscles, especially the outside hip muscles that are classically weak, that I see that day in, day out. And these are areas that can help the knee, help the offload of the force going through the knee.
Thanks. Just another one here. Somebody said they've no difficulty walking, but have very restless leg muscles, particularly around the knee area after hikes, which prevents sleep. Is there anything you can recommend, or is that a tricky one?
It is a little bit. If it's what we call DOMS, or delayed onset muscle soreness, a lot of that is due to muscle fatigue. And a lot of that is due to, I suppose, the endurance and the what you've asked your muscle to do. And again, that can be worked on through gradually building up a strength and conditioning program. And often the more mountain climbing and more hill walking you do, the less time this happens. If it's night cramp only, that's probably a different condition, and that might be unrelated to actual hill walking, and you might need to talk to your doctor about that. Certain medications can cause that, and certain other conditions, non-musculoskeletal, can cause that. But if it's solely after kind of excessive exercise, a lot of that is to do with muscle fatigue and the buildup of lactic acid. There's been lots of research done on what people can do and from a nutrition perspective to stop the buildup of lactic acid, but ultimately lactic acid builds up because of your aerobic and anaerobic thresholds. So if you can build up your cardiovascular fitness and your muscle strength, then the chance of getting that significant soreness or restlessness becomes less and less.
Great. I have two kind of exercise ones here. What balance exercises do you recommend for over 60s? And another one is about, do bike exercises complement the need for hiking?
Just to the balance one, so balance is really important for anyone over the age of 60. The chief medical officer recommends that you do balance exercises at least twice a week. I think I had a infographic on one of my slides that balance exercises, things like yoga, tai chi, things like that can certainly help, but simply just stand at home, standing on one foot and just holding yourself in that position and being safe while you do it can actually just start the activation, and then that gives you feedback into your brain as where the position of your foot and your leg. But there are other techniques you can do. Some people then go on uneven ground. If we're talking about hill walking on uneven ground, then you can start balancing on uneven ground. There are things like wobble boards that you can use, or even if you stand on like a pillow or any of those balls in the gym that give you that balance, then that will certainly help you improve your balance and ultimately prevent falls, which is the big thing as we get a bit older.
Okay, thank you. And the bike,
sorry, the bike for the knee, isn't it?
Yeah. Does it complement?
Yeah.
Does it help? Yeah.
So I suppose it depends on the resistance that you have on the bike. So if you're just have low resistance and you're going bike riding, that probably won't do much for your knee. That will do a lot for your cardiovascular fitness. If you're doing high resistance or going uphill, yeah, that'll start activating your quadriceps quite a bit. But ultimately, I think the bike is there for cardiovascular fitness, and then the specific strength-based exercises would be used for building up the strength in the muscles.
I think you did talk about this. You talk about people if they've any new kind of illness, etc., about getting themselves checked. So someone's just saying they're in their mid-60s, they're a hill walker, they're just about to start blood thinners for AF. Is there anything specific to hill walking they should watch out for?
I suppose if you're on blood thinners, the biggest risk is falling. Because if the chances of you bleeding are significantly higher, not just falling on things like your hip or your muscles, but you don't want to fall on your head as well. So going back to balance exercise is really, really important if you're starting blood thinners. From the AF perspective, from the, I suppose, cardiovascular fitness, you just want to check that you're stable. And most people, it takes a number of weeks, if not a couple of months, just to get that stability. What you don't want is to be up on a mountain and suddenly get a fast atrial fibrillation because you've been a little bit unstable. So it might be worth having a chat with your cardiologist just about saying, look, if I'm going away on a hike and I'm going to be gone for a few hours, when do you think I can start doing that from a stability perspective of my atrial fibrillation? And most of them won't mind you doing it, but it's just about the first few weeks to months just to check that you're stable and that you don't get recurrent episodes. But the big thing with blood thinners is just making sure that you're safe and that you're stable and that you don't fall while up a mountain, and that you let people know that you're on them in case you do.
Yeah, Frank, thanks so much for that. That was great. Okay, thanks everybody for joining us. We do have another talk on the 16th of October on joint replacement, and we will be sending you out the evaluation, so please fill it in. It's always really useful for us to get them back for any ideas and critiques for us for the next talk. Thank you.